Hello and welcome to Checking the Vitals, a podcast powered by Specialty Care. I'm Todd Schlosser, and joining me today is Dr. Michael Firstenberg, an adult cardiothoracic surgeon. In this episode, we take a deep dive into the realm of extracorporeal membrane oxygenation. ECMO has become a very common support for COVID-19 patients, and Michael and I explore the reasons behind that. We discuss how ECMO should be administered, how doctors should determine when to put patients on ECMO, and how it is impacting COVID-19 outcomes. Enjoy the conversation. So, Michael, thank you so much for joining us again here on Checking the Vitals. I really appreciate it.
My pleasure. Happy to be with you, Todd.
And before we jump in, I do want to let the listeners know that we actually had a conversation almost a year ago now. I believe it was June of last year, where we talked through your journey to becoming a surgeon and sort of innovation that you helped sort of spearhead along the way in, ever since you finished your residency to sort of where we are now. And if people are more interested in that sort of background information on you as a doctor, as a surgeon, and as a researcher, I would encourage them to go listen to that episode. I would like to dig into some stuff we only touched on that episode because you were clearly a wealth of information and were super generous with your time then, but have agreed to take some more time, and I appreciate that. So today I'd like to focus on ECMO and why is it important that hospitals or surgeons be involved in running and managing an ECMO program?
So, one of the things that COVID has done is once again bring ECMO to the forefront. I think that there was a huge incremental step in awareness during H1N1 2009 that raised it up to here, and now I think it's almost to the point where most people are familiar with it because of all the conversations, all of the media, and all the interest that surrounded it as part of the fact that it remained almost like a last-ditch salvage therapy for people that were really struggling with COVID. And it's something that, in part of working with collaborators across the country as well as across the world, we did recognize that there is clearly a role for ECMO in patients with really severe COVID, but recognizing that it wasn't the silver bullet that everybody was hoping that all these different therapies were. For those of us that have been doing it for a while, recognize that it's a great tool, will be a great tool, that if used properly, like any other tool, can be very effective in what we want to accomplish. However, we also need to recognize, again, like any other tool, that if not used properly, whether it's the right patient selection or even just how we take care of these patients, that the desired outcome is probably not what is hoped for or expected.
Yeah. So, and I know that you obviously have been working in the cardiothoracic space for a good number of years now. So how do you go about, I guess, when you're managing sort of that ECMO program, and really what I'm super interested in is how you decide what patients go on it, because as you say, it's a great tool, but it's all about qualifying the patient correctly and making sure it's the right tool for that patient. So how do you make that diagnosis?
Well, it's a delicate balance, and that's one of the things that we also have really learned over the past year in studying COVID patients in particular, but also going back as to how we've applied it to other patients in the past. And that is recognizing that there are established scoring systems and, looking at the state of the entire patient to see if they are a reasonable candidate. It becomes a delicate balance because on one side, you don't want to initiate a very invasive and high-risk therapy if patients don't need it. But on the other side of the coin, we also have to be realistic that there are some patients that may be too sick or that are probably not the best candidates for it, and understanding those variables that go into determining whether a patient is a good candidate. And that's something that we really spent a lot of time with studying, not just in the context of COVID, but also in the context of all the other different types of respiratory failure that we've been using ECMO for over the years.
Absolutely. So, and I'd imagine that just like in, sports, I used to have coaches that would say, the more repetitions you get, the better you'll get at it, right? So I'd imagine that ECMO, because of COVID, has seen such not a resurgence, but like it's become much more prevalent, that it seems like a lot more people, a lot more hospitals are adopting and building their own ECMO programs and things like that. Do you think post-COVID, and I realize we're not done with COVID, but we are starting to see maybe a light at the end of the tunnel. Do you think that ECMO will stay more prevalent than it was pre-COVID?
I think yes and no. I think that there is a reality that it is an effective tool, and I think it is also a reality that it is very, as we say, resource intensive. It really takes a lot of people to manage it. It's not something that is really a reasonable option for many, let's say, small community hospitals
Right.
or programs. One of the things that came out of the early recommendations was that uh, this was now not the time for you to start an ECMO program at your hospital if you didn't already have one. There's a huge learning curve, as you sort of alluded to, with regards to patient selection and management.
Yeah.
And, if you have a program, this is great. If you don't have a program, this is not the time, to learn, given the pandemic. Maybe when things kind of settle down a little bit, or hopefully they will, that then that's when people can get those expertise. It's like, you don't want your first race to be the Olympic marathon. You kind of
Right.
want to get up to that a little bit quicker.
Right. Yeah. You want to train in less high risk situations.
Correct. Yeah,
Yeah.
because there's clearly plenty of cases that I've heard about where people have embarked on treating patients with ECMO that really got in over their head pretty quickly for a
Yeah.
variety of reasons that are probably not really appropriate to talk about here and now. But
Sure. Yeah.
people mean well, for the most part. At least that's what I want to believe. But I think we also have to be honest that sometimes this is not the best therapy, and it's very difficult when you're looking at somebody who's relatively young and maybe previously healthy to say that we're not going to offer you a therapy because we don't think that it's going to work. Rarely in medicine are things that cut and dry, but I think it's also important to be honest with regards to potential limitations of anything that we have.
Yeah. And not to get too high level with it, but I mean, really, ultimately, it's all about patient outcomes. And
Right.
you, as the expert in the room, are the one that needs to be the determining factor as to, is this therapy correct for this patient?
Right. And that's where some of these scoring systems, for example, come in. And that is, we're able to recognize, okay, so when you're looking at a patient at the bedside and they're struggling, and clearly this is something that you really need to evaluate almost, you don't have the time often to convene a committee and say, well, let's see what things look like next week. You really
Right.
have to make some quick decisions. And, looking at where that patient is right now with regards to collectively, not only what does the data say in terms of what your projected outcome may be in terms of scoring and percentages, but also being honest with regards to your institutional experiences. If you're a big center and you do a lot of it and you have a lot of staff and resources that are used to taking care of it, that's a completely different picture than if you're, let's say, a program that does not as many of them, and you're still on your learning curve and your staff are not used to dealing with this kind of stuff.
Actually, sort of to that end, because it sounds like to me we're talking about like key learnings or key takeaways that you've come up with, or that maybe you and your colleagues have come up with
Yeah.
through COVID, because you guys work with ECMO a lot in the cardiothoracic space. So what are some other key takeaways that you might have, aside from it's not the right time to start one?
Yeah.
And qualifying the patient is paramount.
Well, you really have to kind of make sure that everybody kind of buys into it with regards to the team. A lot of the things that I've written and talked about over the years is how you develop ECMO programs. And one aspect of it is that, more so than any other area of medicine, you have to have people, collaborating together, not just surgeons, but you have intensive care doctors, pulmonologists, respiratory therapists, perfusionists, pharmacists, nursing, administration. Everyone's got to buy into it. And people may fundamentally say, yes, we want it, but they also then have to walk the walk in addition to talking the talk, because
Yeah.
it can be a lot of work. And if you don't have people that, a chain is only as strong as its weakest link. And if you don't have people
Yeah.
that completely are willing to do what it takes, then you're going to struggle.
Yeah.
And and that's something that you have to be honest from the very beginning, because it really does require a lot more work and also a little bit of a change in philosophy sometimes with regards to how care is delivered. And it's difficult to say that without being critical, and I don't mean to be critical, but sometimes people have to change their practice patterns. So we'll pick on surgeons for example.
Sure.
It's easy for us as surgeons to say yes or no whether we want to be involved with it. But it also may mean that changing how we practice things. We may have to cancel our elective cases. We may have to change how we come around at different hospitals. I mean, it's a completely different mindset sometimes, and you have to be willing to adapt to that type of collaborative effort more so than what you've done in the past. And if it doesn't work for you, then it's not going to work overall. And that's why, for example, a lot of programs, and this is something that is very hotly debated and discussed, at our society meetings, is, what are the key elements for an ECMO program? Do you have to have surgeons? Well, a lot of places don't have surgeons because the surgeons, don't have the ability to buy into it, so to speak, as much as they may want to. And the program is able to develop a system that works for them independent of key players. So, you can't always take a model that may work at this institution and completely replicate it for a different hospital because everybody is different.
Yeah. And they say, all healthcare is local because really the resources you have at that location really sort of dictate what program you can run, what program you can start, if you can start a program, a lot of those things. And I think it's important that you brought up the staff buy-in, for lack of a better term, because I know for a fact that perfusionists, it changes the way they sort of practice, right? Because perfusionists usually run a heart and lung machine, as you well know, because you're in there with them. They run the heart and lung machine while you're operating on the heart.
Yeah.
Now, with ECMO, they are bedside with the ECMO machine sort of the entire time the patient is on ECMO. So that's a very different from, a few hours in surgery to your entire shift is sitting there next to an ECMO machine, making sure it's keeping the patient going.
Right. No, and COVID was such a beautiful example of that because what ended up happening simultaneously, and perfusionists play such a critical role in this, in that, on one side you need perfusionists, which are a very specialized area of medicine, and they're already in limited supply to begin with. You need them to do your heart surgery cases.
Yes.
But on the other side of the coin, you also will often need them to help take care of the ECMO patients. And there's only so many of them around. You can't have a perfusionist working 24 hours a day, sitting at the bedside, but then also expecting them to run your heart surgery. And so one of the things that we did see during some of the peak COVID months was a somewhat predictable and understandable decrease in the amount of heart surgery that places were doing, which then freed up those other resources, including the perfusionists, to help take care of the ECMO patients. So it became a little bit of a balance. But when you disrupt that balance for whatever reason, then it becomes a challenge. And then so, for example, if you have a program that does, let's say, 150 heart surgeries a year, and that's how they're structured and that's how they're resourced, they may not be able to all of a sudden adapt to being able to take care of 15 to 20 ECMO patients. They just don't have the people for it without being disruptive to the other aspects of it. And so I think that's something that you really have to be honest about. I mean, there are, everyone's willing to go the extra yard, but we do get to a practical aspect of it. And to get back to some of your patient selection, that was something that was very actively discussed at a lot of institutions, and that is how much ECMO can we do sometimes.
Sure.
Nobody wants to say no to the 23-year-old college student that comes in, but on the other side of the coin, if you have a 60-year-old and they are a diabetic and they're morbidly obese and they have bad, lungs, those decisions are a little different in terms of how we do triage medicine sometimes. And many programs set up criteria, not just in terms of selecting the patient, but recognizing that patient selection criteria changed depending on how many other ECMO patients they had or how many other patients they had in the ICU. It's much like how the speed limit changes, depending on the weather.
Yeah.
You have to recognize, what's going on in your surroundings, in your environment, and not just practicing in that vacuum.
Yeah. Well, I mean, and in the patient, you're looking for things like, has COVID, and obviously correct me if I'm wrong, but has COVID progressed to, ARDS, where it's like acute respiratory distress syndrome, I believe. Forgive me, I'm not as well versed in it as you are,
No, that's
but
good.
yeah. So you want to make sure that they haven't progressed too far down that path to where ECMO may not help them.
Yeah.
Although, acute respiratory distress might actually be helped by going on ECMO because it'll give the lungs a break. So it's sort of a delicate balance there. And one that I imagine is unique to every patient.
Yeah. Well, and the ideal ECMO patient, whether it's COVID, flu,
Sure.
or anything else, actually is the adult respiratory, the ARDS patient, which is kind of a wastebasket term.
Yeah.
That the only problem that they're suffering with is what we call isolated single organ injury, meaning it's just the lungs.
Yeah.
And because given enough time, those patients will then, more often than not, unfortunately, then progress to what we call then multi-organ failure, where the inability to get enough oxygen as well as clear off the carbon dioxide and the interventions that you have to do to stabilize that will then start having effects on other parts of the body. So going into kidney failure, going into possibly their liver not working, having an obvious impact on their heart. These all these things start adding up over time, and then other what we call systemic problems where they start getting hypotensive, meaning low blood pressure, and then adding that on to any existing medical problems that they may have only starts this accelerated downward spiral. And you want to get to the point where you're not before you go down that spiral, because once you start going down, it becomes very difficult to break that and start coming back up again.
Yeah. So, I mean, you obviously want to stop the negative effects before they continue to
Right.
spiral downwards. That
Right.
makes complete sense to me. So, what is your experience sort of, well, let me phrase this question a different way. So, as we come out of COVID, let's pretend we're in a world currently that is post-COVID, even though we're not. If a hospital is looking into, okay, maybe now is the right time to start an ECMO program, and I'll obviously let you speak to whether that is the right time to start it, how would they go about doing that?
Well, I think the key thing is asking, do they do heart surgery to begin with?
Sure.
Not every hospital does heart surgery. I don't know what the current percentages are, but I thought somewhere around only about 15 to 20% of major
Wow.
hospitals in this country do that.
I didn't realize it was that low.
And don't quote me on those numbers, but
Sure, sure,
but,
sure,
but the
sure.
point is, when you look around, in most of the cities that I've lived in, been at, knowing them, a lot of them don't have heart surgery programs. I think it would be very difficult to start from scratch with an ECMO program if you're not already doing heart surgery.
Right.
Not only do you, to a certain extent, need the relationship with the surgeons, but as you mentioned, the perfusionists, and in taking care of some of these, critically ill patients that often, come with heart surgery as well.
Yeah.
So I think that's probably the first major obstacle. It's probably not an overwhelming obstacle if you don't do it, but it does make things a lot more difficult. And I think once you do that, I think the important thing is getting all of the key disciplines together, sitting them down at the table, so to speak, and making sure that everybody is committed to what this entails. And especially from the very beginning, talking about having surgery, having the critical care doctors, having perfusionists, having nursing, having pharmacy, having those key disciplines, sitting around and saying, this is something that we want to do. And from there, recognizing, okay, again, in the concept of learning to walk before you run, many
Yeah.
programs, to a certain extent, may do occasional ECMO, meaning they have the ability to do it, but they may not necessarily have a program to do it. And building upon those experiences, and usually what ends up happening when they first start doing it, let's say they'll maybe put somebody on ECMO because they can, and then transferring that patient to what we call a higher level of care. Let's say a major ECMO center, a
Sure.
university program, or some existing hospital that they have a relationship with sicker patients. And over time, they'll get more and more comfortable with kind of keeping those patients in their own hospital. So it's a matter of recognizing, the different phases of that growth in terms of, which patients you want to keep in your own hospital and whether it's appropriate to keep them, and then versus which ones, you need to send out.
So you'd recommend, if you do have the equipment, but you don't have the know-how, that, if a patient direly needs to go on ECMO, get them on ECMO and then get them to somewhere that has a program, right? So how does, I guess, if you're looking to start a program, and let's say you have a cardiac surgeon that makes rounds at your hospital and you have the infrastructure, like, I understand why you need to have a heart program to do this, because that provides the infrastructure of perfusionist surgeons, all of that stuff. But how does it, I guess, how do you view sort of working with an outsourced provider for ECMO services to start up a program? Because they might, and obviously, correct me if I'm wrong, they already know how to do ECMO. So they're bringing in that knowledge and that know-how, whether you have equipment or not. That may help if you can just plug it into your already existing system.
Sure. Well, I think a lot of it goes back to, again, some of the basics that you've mentioned before. One is helping a team-based approach for identifying the patients, and then once a patient is identified based upon, pretty much established criteria that's been published, then the next step is deciding, okay, who is physically going to put them on ECMO? And that's usually where the surgeons come in. And that's where the surgeons have to be comfortable, not only in physically doing it, but also being available to do it sometimes on relatively short notice. Some of the programs I've been at and helped start in the past, we would get called at 2:00 in the morning to put somebody on ECMO up in having when they've just delivered a baby, and we had them on ECMO at 2:00 in the morning, within 20 minutes. I think our record is 23 minutes.
Wow.
And so so identifying those kind of key steps and then working out those crucial relationship issues between, let's say, the surgeons and the ICU doctors, as well as the perfusionists, as to who then is going to play the key steps in managing those patients. And while we talk about how perfusionists often are the ones that are sitting at the bedside managing the pump, they just take care of the pump. Now, they have invaluable experience in managing the entire patient, but that is something that has to be recognized. And that is sometimes something that they don't always feel comfortable with. So the next step in that is making sure that the ICU doctors and the nurses feel comfortable. There are models of care where the ECMO machines are managed by respiratory therapists, but that is something that comes much further down the road.
Yeah.
And then it gets into, all the day-to-day issues of taking care of the patient, making sure all the details are taken care of, managing the pump, managing the expectations of the family. We often will get hospice and palliative care services involved at the very beginning, not necessarily to say that we're giving up, but to utilize that resource in helping patients or helping families deal with the reality that there's a pretty high likelihood that their family member may not survive.
Yeah. And I know that, as you mentioned, the respiratory therapist taking over bedside by the ECMO patient, a lot of that is because of the perfusion shortage that we have in the United States currently. Obviously, again, correct me if I'm wrong, and that perfusionist shortage has been going on for a good number of years. So are you seeing, from I would say, a leader of the surgical team perspective, are you seeing any efforts being made to address that perfusionist shortage?
The short answer is I don't think so, other than recognizing, as I mentioned, that some of these ECMO programs, knowing that perfusionists are in very short supply, are transitioning to having other types of providers being at the bedside, taking care of the pump. And so, like, for example, one program that I was at, when we first started, we had perfusionists managing the pump and being there 24/7, to the point where then it evolved into something where respiratory therapists were much more engaged and involved, and the perfusionists were able to go home. They were able to get some sleep. They were available as a resource being on call, but more importantly, they were able to then continue on with what they were needed most, and what they excelled at most is is doing heart surgery, during the day. There's, a lot of times, babysitting these patients, as we call it, is just essentially sitting there and just watching the pump go round and round
Yeah.
and responding to any alarms or problems that come up. But the technology's gotten so good lately that that is not as important as it was, let's say, 15, 20 years ago. And so so there aren't really good ways of ramping up the number of perfusionists. We're just trying to find ways of using them smarter. Going back to the what was it, Jack Welch from GE, in his book about management, it's not working, it's not working harder, it's working smarter.
Yeah.
And that's what we're getting at. Because perfusionists, they're very highly trained. They bring a very specific level of expertise that really in many areas can't be replicated by anybody else. There is nobody else in the hospital that can run a heart-lung machine in the operating room, nor should there be.
Yeah.
Starting programs, it's a multi-year training program. Starting programs up is not easy. And, so we just have to recognize that's a high demand area. There were some dynamics that happened in heart surgery 10, 15 years ago that at the time, there was concern that there wasn't going to be as many cases being done and maybe not enough need. And so maybe things got scaled back a little bit and we're starting to see the repercussions of that. But the reality of it is we just can't turn out twice as many of them, in a year or two.
Yeah. And I mean, it is for most programs for perfusion, it's 18 months, 2 years, I think, to go from, already having a science degree to being a perfusionist. So it's not like it's something that can be fixed overnight.
Yeah. And in many places, there's been a lot of debate about whether it should be a master's level program. And I think, probably most importantly is activities, like these conversations where people, start hearing that perfusion services or perfusion sciences, is a real profession.
Yeah.
Even going through medical school or early on, I had no idea what that job entailed. Unless you know somebody that is in that area, you would never know that there is a profession that that basically is based upon just running a heart-lung machine. And I don't want to minimize what they do, because I think it's a lot of work. It's requires a lot of science and biology and chemistry and a lot of education and hard work. But and my understanding is that it actually pays pretty well to in response to that. But there's no there's no TV show. There's no there's nothing that brings that profession to attention. So hopefully these kinds of things will.
Yeah, no, absolutely. And I can't tell you how many people I talked to who are perfusionists who, when I ask them what made you want to go into perfusion, they will say things like, well, I had no idea perfusion was a thing. My mom, who was a nurse or a surgeon or whatever, told me about it and I got interested in it. And I realized that in 2 years I could be making great money and I was interested in it anyway. So it's where I went. So I think that that's a very, very astute observation that a lot of people just don't know it even exists. And once they do, they realize it's, I think personally, a very good career.
Yeah.
Although I lack the knowledge and skills to do it myself, because it does take quite a bit of education and schooling to get into it. But
I'm sure you could do it. If you get all this other stuff working, a lot of this stuff is just dedication and hard work.
Really, all it is going to the school, right? And I do know that the number of perfusion schools, just because of these conversations that I have all the time, the number of perfusion schools have diminished over the past 15, 20 years. And now, I think as of a year and a half ago, the number hopefully hit its floor and is starting to grow again.
Yeah.
So hopefully, but again, it's a 18 months, 2 year program. So it'll be 5, 10 years before the perfusion shortage starts to let up.
Right. And it's almost like, becoming a pilot to a certain extent. There's, you clearly don't want to cut corners in your training,
right.
And, in the sense that, and you need a lot of on-the-job experience, but that on-the-job experience has to be supervised and in an environment that is best, for the patient. Much like, you don't want to step foot in a jumbo jet that, the pilot, this is his or her first time flying the plane. It's the same thing for heart surgery. And so, you know, a lot of these types of professions do revolve around almost like a mentorship. And
Yeah.
that's why, there's not, opportunities for just starting a program, kind of willy-nilly. It's not something that you can, train for online. It's not something, while everything is evolving to, let's say, Zoom calls
Yeah.
and virtual meetings in education, much like, my son, who's at the University of Michigan, hasn't stepped foot in a class in, I don't know, 9 months, despite paying all that out of school tuition.
Oh, yeah.
A lot of these jobs really require you to actually turn the knobs and clamps and dials and all those kinds of things. And that stuff doesn't always come easy. And there's
Yeah.
not a lot, and we have to make sure that there's a safety net ultimately for the patient to protect them while some of this training and education is going on as well.
Absolutely. And I'm sure that same sort of mentality of you got to get that repetition again. You got to get your hands on the ball, for lack of a better metaphor,
Right.
but to be able to do the job, right? And I'm sure that transitions from, a heart and lung machine to an ECMO machine.
Right. And again, much like, although I don't know the specifics of flying an airplane, having talked to enough pilots over the years, I think it's very similar. For the most part, with probably very little, experience, people like you and me could probably, fly an airplane. Okay. But the reality is it's the taking off, it's the landing, and it's, as we saw, in Denver a couple weeks ago, it's what happens when your engine catches on fire.
Yeah, absolutely.
It's look at Sullenberg and what happens when you have to land in the Hudson.
Yeah.
There's so much of what we do has to then take into consideration that 90% of the time everything runs smoothly, but it's that 10% of the time that all that training and education and insight and judgment comes into play.
Absolutely.
I find that everybody, when we talk about, let's say, basic heart surgery, nobody wants heart surgery. I get it.
Yeah.
Nobody wants
Yeah.
to pay their taxes, but at the end of the day, there is sometimes some benefit that come from these things, and people
Yeah.
need to understand that. And on the other side, along that lines, everyone's always afraid of it, and what we fear most is the unknown. And so part of the conversations that I have with patients and their families is making sure that they understand what we're doing, why we're doing it, giving them not only the opportunity to ask questions, but also then follow-up questions so that they're more comfortable with what we're doing. And the more that they have that degree of comfort, the more it takes away from whether it's the ambivalence or whether it's the apprehension or just the fear or anxiety that comes with these things.
Yeah. And I'd imagine that in a lot of these situations, there's a dire need for heart surgery. It's not like someone gets a idea of, I need heart surgery. It's hey, you need heart surgery.
Right.
So, and you have to prepare your family for that. So it's not just the patient that you're dealing with as a surgeon, as the leader of the OR team, if you will. It's sort of that person and their community around them.
Right.
So, because if the worst happens, you're not talking to the patient about it.
Yeah.
You're talking to the family about it. So you want them to you want to set clear expectations. And I completely
and so much of all this stuff is managing the expectations. And I think that's why, we struggled a little bit with COVID, was that, we had no expectations, or that the expectations were, well, why can't just science just come up with a vaccine and make it all go away? Because that's kind of how we're used to problem solving. The government, the way that the government solves problems is they put a ton of money at something and the problem goes away. But biology and science and doesn't always, kind of, as we say, they don't read the same book that we do sometimes.
Well, and if you look at science over the era that humans have been on the earth, it is very slow. I realize it progressively gets faster and faster and faster. And the fact that we got a vaccine for COVID so fast is amazing to me. It just blows my mind. I mean, there's no even correlation to the speed at which we got the COVID vaccine out. And we have 3 different ones.
Right. And to a certain extent, I think, there was a component of luck that came into it.
Yeah.
The fact that people had already been studying this a little bit, so they were able to kind of shift gears a little bit. And I think that there really was a true, whether it's global commitment to trying to build on something. I mean, remember, people have been working on an HIV vaccine, for 20 or 30 years.
Yeah.
And even some of the routine vaccines that we get as children these days, many of those took, years, if not decades, to kind of bring to market. I'm not saying that we cut corners, but I think, part of it also recognizes that the landscape was different. There was a little bit more of a more pressing need, and that we were able to do it, as in the past we may not have been able to do it.
Yeah.
And to be honest, I think we also have to keep back in our mind that, we may be, paying some consequences, for moving things through as quickly as we did, compared to other stuff. Just look at all the controversies going on now. There's still all this debate about the dosing. There's still all this debate. I don't think anybody knows what vaccine quote is best. And I think, I think it was Fauci that said, you get the vaccine that you're offered.
Yeah.
And whether there truly is a difference between one that's 85% effective versus one that's 90% effective. What that all means is still something that is very hotly debated. And I think at the end of the day, the vaccines that we have out there, I know we're getting a little off tangent, essentially reduce the risk of severity of infection if you do get infected.
Yeah.
And that in itself is what makes things worthwhile.
Yeah. I do think, though, to sort of refocus us, I do think that, I don't want to say silver lining from COVID, just because there's so much bad stuff that happened because of COVID, but I do think that the way the world community, the world health community, focused on this vaccine and getting a vaccine or just any way to treat COVID, whether it was new techniques like ECMO or implementing in a different way or things like that, I wonder if that will continue on in like a global health focus on, heart disease or cancer? Or do you think that because of the way we attacked the COVID vaccine, that will change the way we approach, those chronic illness researches that are always going on?
Yeah. I think the short answer is maybe. I know I know that's a little bit of a hedge, but we already do have a lot of these mechanisms in place for doing some of this stuff. We have what we call orphan drug programs. We do have mechanisms by which companies can bring new technology to the bedside, relatively quickly. We do have, this infrastructure that is set up. Is it perfect? No. And I think one of the things that we have learned is opportunities for improvement. I think at the end of the day, there is still this check and balance that has to occur with regards to how we develop technology and we use it on people, that there is that safety net to make sure that what we're doing is safe and it's appropriate.
Yeah.
And that and so it's important to be able to move at warp speed as we did, hence the name.
Yes.
But there also has to be enough regulatory and monitoring oversight to make sure that we're not overstepping our bounds and pushing things that are very quickly, and making sure that the things are based upon sound science rather than just sometimes a political agenda that we're seeing.
Yeah, absolutely. Some people are concerned because 2 of the 3 vaccines are a different kind of vaccine than like the Johnson & Johnson one is sort of a regular vaccine that you would normally get for other things. It's also a single shot.
Yeah.
Whereas the mRNA vaccines are 2 shots, and the mRNA part of that is what I think a lot of people are concerned about in that sense. And that's why Fauci, when you referenced it earlier, said you sort of get whatever vaccine that you're being offered because they're not being offered everywhere. But, as far as Fauci's concerned and the CDC is concerned, you should get vaccinated from whichever one you can, right?
Yeah, no, I agree. And I have to admit that, as I started, naturally, particularly as somebody who prides himself as being a physician scientist, I try to keep an open and skeptical mind, because you need to have that, not necessarily just cave into an overwhelming sense of optimism sometimes.
Right.
But I think it's important to be, to objectively look at the data. I have a very good friend of mine. Her son has a genetic disorder that we've been debating as to how we're going to, get him treated for it. And one of the roadblocks to him getting the therapy that he needs is he has to have a vaccine to come into a facility to be treated.
Yeah.
And he says, to his mom, he said, "Mom, I don't want to get the vaccine because I have enough problems as it is. And I don't want, I have issues with my immune system, and I don't want a vaccine potentially making it worse." And I think that is a legitimate concern. But on the other side of the coin, when you look at the balance of some of these things, as I think, the CDC is recommending and talking about, and that is, a lot, these are not binary things that we look at, and a lot of what we deal in medicine is risk-benefit ratio. It's, what is the greatest benefit for the least amount of risk? And that may change from person to person, and it may change over a population. And so, granted, there may be some, real or even theoretical risk to some of these vaccines that we may not know about, both short and long term.
Sure.
But when you offset that, with the known risk of potentially getting infected, then that's where the equations come in. And those are the conversations. My brother, has been very concerned that he has not been able to get vaccinated.
Yeah.
He's 10 years younger than I am, give or take. Sorry, Josh, if I missed out on that. It was his birthday a couple of weeks ago.
Well, happy birthday, Josh.
And he's very concerned about it. And I said, "Josh,
Yeah.
You are in a very low risk group. Okay. I mean, granted, no, I wouldn't wish this on anybody.
Sure.
But even if he were to get COVID, chances are his, it would be a relatively mild course of it, and his long-term consequences of it would probably be relatively minimal. We can discuss, the social aspects of it another time. Sure. Offset that with, when you have a limited resource like a vaccine. Again, this gets back to, I don't remember who the philosopher was, the social scientist, it's, and maybe it's, from Spock at Star Trek, and that is, the needs of the society outweigh the needs of the individual.
Yeah.
And so at what point, do you have a limited resource, whether it's a vaccine or ECMO, as we were just talking about, and how do you allocate that in a way that it serves the best needs of society in terms of reducing the amount of potential, not just deaths, but severe illness. And so that's where and that's why people think these decisions are political, but to a certain extent it is, social politics, and it is, different for a state like Florida, where the demographics may be very different than, my home state of Ohio.
Yeah. On the other flip side of the people who may be concerned about the mRNA vaccines, I have a good friend who is very happy about those vaccines because she's allergic to eggs and she can't take most vaccines, but the mRNA vaccine she'll be able to take. She's also in a low risk group, so she hasn't been able to take it yet. But yeah, so there are positives to that. And I do understand that long-term effects, we need to be able to, research it long-term and make sure that I guess we knew what we were getting into, even though we really weren't. We don't quite yet know what the long-term effects of the vaccines will be, but we also don't quite yet know what the long-term effects of a lot of things are that get introduced into large populations of groups. So that in and of itself is not uncommon.
Right. And to a certain extent, that's why at least I've been so interested in some of this, because the mental exercises, so to speak, have tremendous overlap. In heart surgery, we often have to make, substantial decisions based upon limited data, limited information. And we can only make good, as I say, we can only make good decisions based upon good data.
Sure.
If we make good decisions based upon bad data, that's luck. If we make bad decisions based upon good data, then that's, an educational opportunity, as we say. But, as we've been moving through this, and I know people have been very critical at every step of the way, we are just trying to make the best decisions that we can based upon the best available data.
Yeah.
And we do, sometimes we extrapolate quite a bit, and that's where the debate comes in sometimes, whether those extrapolations are appropriate. And that's why, there's a lot of controversy. And then, toss in, conspiracy theories and people that have had anecdotal experiences, or frankly, people that don't necessarily understand, the science or the data or the politics, or the fact that really the devil is in the details of all this stuff.
Yeah. And I'll say this, I have some friends that are leery of vaccines sort of in general. And I would put a conversation like this, where you are what I would consider a healthcare and research expert. I would take your word over anyone I'm watching on YouTube any day of the week. So I think that's what I choose to sort of go with, right? And listen, I just don't want to take the time to learn everything that you've learned. I don't necessarily think I couldn't have, but at this point, I'm not gonna. So I'm gonna trust the people who have put in the time to understand these things fully, because I clearly do not.
Yeah. Well, and to a certain extent, I'm not saying that I necessarily understand the stuff fully, but I think I know enough that at some point I have to make a decision. So for example, when these vaccines first started coming out and we were a little unclear about the data, a key part of all this was recognizing that whether I agree with the vaccine or not, and by the way, I do agree with it.
Yeah.
That if I personally did not get vaccinated, then there was going to be a point in time where I was probably not going to be able to do my job. Okay. Meaning, whether I believe in it or not, they were not going to let me in the front door of the hospital. Okay. There is going to be probably a point in time, and there is precedent, and there is Supreme Court precedent for this, and law that says, we can restrict activities based upon your vaccination status.
Yeah.
And I've been working on a couple of writing projects along that, because I think it's a brilliant ethical dilemma, as we're seeing apply right now. So from a practical standpoint, you personally may not be able to get on a cruise ship. You may not be able to get on an airplane, and go to Disney. You may not be able to go to a movie theater. You may not be able to go to a football game. You may not be able to do a lot of things that you normally do unless you have been able to prove that you're vaccinated. And that changes the dynamics completely, whether you agree with the medicine or not, because now it's a social public policy debate more than just whether you believe in a vaccine or not.
Absolutely.
And we're going to start seeing situations much like we have now, where, you and I probably don't even recognize this, and I think I have a few years on you, but a lot of times you couldn't go to school unless you had your measles, mumps, and rubella, and your chicken pox and your smallpox and all that kind of stuff. This, to a certain extent, this may not be any different.
Yeah.
And if you're going to refuse it, you're going to have a pretty substantial, objective reason for it, and not just, I don't believe in it.
Yeah. Well, I just want to thank you so much for being here on Checking the Vitals with us, Michael. I appreciate it.
No, anytime.
Thank you for listening to Checking the Vitals. If you enjoyed the content we provide, please leave us a 5-star rating and review. It really does help people find the show. And make sure you subscribe so you hear our interviews with healthcare innovators every Monday.